Hello, I'm Eric Strong from Strong Medicine. In today's lesson on cardiovascular physiology, I'll be discussing the cardiac cycle and PV loops. By the end of the video, you'll be able to describe some of the nuances in the changes in intracardiac volumes and pressures during the cardiac cycle. You'll be able to draw a normal pressure volume loop and describe how it's changed by pathological processes. And you'll be able to qualitatively describe cardiac work and myocardial oxygen consumption. I introduced the concept of the cardiac cycle in the first video in this physiology series. To remind you, we looked at the famous Wigger's diagram, which illustrates the distinct pattern of pressures, volumes, and flow that occur within the cardiac chambers over time. Today, I'm going to go beyond the basic principles that were introduced then, and we'll discuss some more of the nuances. In this version of the Wigger's diagram, I'm including only the typical tracings for the aortic, atrial, and left ventricular pressures and for ventricular volume. I'm leaving off the timing of heart sounds and ECG waveforms present in the more common version of the diagram because they are not directly relevant to the scope of this particular video. Systole, the portion of the cardiac cycle that includes contraction, starts at this point right here, the point immediately after the ventricles begin to contract, when the LV pressure exceeds the LA pressure, causing the mitral valve to snap shut. But the aortic valve does not open at the exact same moment. It takes a tiny amount of time for the LV pressure to continue to build up until it exceeds aortic pressure. During this period of time between mitral closure and aortic opening, no blood is moving into or out of the LV, so its volume is constant. This brief period is known as isovolumetric contraction, or occasionally as isovolumic contraction. Likewise, after the LV begins to relax, when the LV pressure drops below the aortic pressure, the aortic valve will snap shut, but it takes a tiny amount of time until the LV pressure dips below the LA pressure, opening the mitral valve. Once again, LV volume during this time is constant, and this period is known as isovolumetric relaxation. When pressures and volumes are diagrammed as a function of time as they are here, these two isovolumetric periods seem too brief to be significant. However, their importance will be more apparent in a few minutes when we talk about PV loops. And despite this particular version of the diagram suggesting that the two periods are roughly the same in duration, in healthy hearts, isovolumetric contraction is even briefer than isovolumetric relaxation. Another nuance in the Wigger's diagram is this little divot right here in the aortic pressure that occurs in early diastole immediately after the aortic valve shuts. This is known as the dicrotic notch. The notch is typically neither visible nor palpable on examination of the peripheral pulses, but is something that can be readily identified by directly transducing the aortic pressure in the cath lab and may be visible on a tracing from an arterial line placed at the bedside. The mechanism behind the dicrotic notch is sometimes said to just be the aortic valve closing, accompanied by a lot of hand-waving as to how precisely that would lead to the notching effect, but there is actually less consensus among physiologists on its cause than some medical textbooks suggest, with the different theories falling outside the scope of this course. The last nuance from the Wigger's diagram that I'll discuss today is the most clinically relevant, the venous waveforms. Because no valve separates the right atrium from the SVC, pressure changes within the right atrium at different points in time during the cardiac cycle are transmitted to the central veins, which are very distensible, leading to visible changes in their degree of dilation during the examination of a person's neck. You can see that in the atrial and venous pressure tracing, there are several relatively low amplitude, but nevertheless distinct peaks and valleys. This provides a window during the physical exam into intracardiac hemodynamics. The A wave represents the momentary increase in venous pressure due to atrial contraction at the end of ventricular diastole. The smaller C wave, which stands for cusp, is due to upwards bulging of the cusps of the tricuspid valve during early ventricular contraction. The C wave is not usually visible on exam as a distinct waveform and thus has minimal clinical relevance. But the C wave is followed by the X descent, which is due to atrial relaxation and downward motion of the ventricles as they contract. Then, in late systole, as blood is returning to the right and left atria from the periphery and lung respectively, the pressure gradually builds up again, creating the V wave. And then, after the ventricles relax and the tricuspid and mitral valves open, blood quickly moves from the atria into the ventricles, resulting in the Y descent. As I said, aside from the C wave, the other waveforms and descents are often visible on exam, and abnormalities of them can provide insight into complex intracardiac processes, including arrhythmias, valvular dysfunction, pericardial tamponade, and restrictive cardiomyopathy. I'll now move on to discuss pressure-volume loops. While the Wiggers diagram is a time-dependent way to represent intracardiac pressures and volumes, PV loops are a time-independent representation of those hemodynamic parameters. They are very roughly analogous to the flow-volume loops in respiratory physiology. You may recall this diagram from a previous lesson on cardiac mechanics, in which the normal relationship of left ventricular pressure was graphed as a function of left ventricular volume during diastole, and it was compared to that relationship in a patient with poor LV compliance, where at any given volume, the pressure would be higher because the ventricle is more resistant to being stretched. This graph will be our starting point for drawing a PV loop. That black, slightly curvilinear line is formally called the end diastolic pressure-volume relationship, or ED-PVR, and as was implied, its position and slope are dependent upon LV compliance. When the LV is at end diastole, no matter what its volume is at that moment, the combination of LV volume and LV pressure must fall somewhere on this curve. There is a point on this curve, which I'll label point 1, which is the moment of mitral valve closure, when diastole switches to systole. The LV pressure at point 1 is called the LV end diastolic pressure, or LV-EDP. LV-EDP is important as it's a primary determinant as to whether a patient with cardiac dysfunction develops pulmonary edema, which is an increase in fluid within the interstitium and alveoli of the lungs, leading to shortness of breath and hypoxemia. If you recall from the preceding section on the cardiac cycle, the very first moments of systole are occupied by isovolumetric contraction. The LV contracts, rapidly increasing its pressure, during which no volume is ejected until the LV pressure exceeds the aortic pressure. This is represented on the PV loop here, where point number 2 corresponds to the aortic valve opening, and the pressure at point 2 is equal to the diastolic blood pressure within the aorta. As blood is ejected from the LV during systole, the LV volume decreases on our curve with a dome-type morphology to the pressure until reaching point number 3. Point 3 occurs after the LV starts to relax and the LV pressure has dipped below the aortic pressure. Regarding the LV volume that corresponds to point 3, this is determined by the end systolic pressure-volume relationship, or ES-PVR. Unlike ED-PVR, which is slightly curved, ES-PVR, as determined experimentally, is linear. The slope of the line is determined by contractility. The higher the contractility, the steeper the slope. Regarding systolic blood pressure, unlike the diastolic blood pressure, which was equivalent to the LV pressure at point 2, the systolic pressure is not at point 3, but rather at the peak of the curve connecting 2 and 3. Keep in mind that when I'm referring to the systolic and diastolic blood pressures, specifically in this context, I'm referring to those pressures as measured in the aorta, which, as we'll see in a future video, are not precisely equivalent to those pressures as measured in the arm or leg. At this point in the cardiac cycle, the heart undergoes isovolumetric relaxation, moving to point 4 on the PV loop, which corresponds to the moment that the mitral valve opens. And then with diastolic filling, the heart moves up the ED-PVR curve back to 1. The difference in volume between 2 and 3 is necessarily equal to that between 4 and 1, and is equal to the stroke volume of the heart, that is, the volume of blood ejected from the LV with each heartbeat. And that's the PV loop. We have 4 distinct points representing the moment a valve opens or closes, and 4 distinct sides to the loop, representing isovolumetric contraction, systolic ejection, isovolumetric relaxation, and ventricular filling. There are two pressure-volume relationships, ED-PVR defined by compliance and ES-PVR defined by contractility. We can identify systolic and diastolic blood pressure, as well as the left ventricular end diastolic pressure. And last, we can directly visualize the stroke volume. Although theoretically, PV loops can be constructed for the right side of the heart, when you see a PV loop, it is almost always a representation of what is happening on the left. If you remember nothing else from this video, it should be this image. Over the rest of the section, we'll discuss how different derangements of preload, afterload, contractility, and ventricular compliance all influence the PV loop. One principle that the examples will all demonstrate: no matter what we do to our heart regarding those four parameters, every part of the PV loop stays to the right of the ES-PVR line and stays on or above the ED-PVR line. Those lines themselves might shift due to pathology or due to the administration of medications, but if they do shift, the PV loop is still constrained to whatever their new location or slope happens to be. So let's go through 7 scenarios, all of which have common clinical relevance. First is increased preload, as we might see from the rapid infusion of saline. As I discussed in the cardiac mechanics video, we can use either LV end diastolic pressure or end diastolic volume as a surrogate for preload. For PV loops, it doesn't actually matter too much how we define it. When we increase the preload of the LV, we move point 1, the point where the mitral valve closes, up and to the right on the ED-PVR curve, and the peak of the systolic ejection curve is higher. The other two sides of the loop look similar. There are 3 hemodynamic consequences that we see from increasing preload. First, our stroke volume has increased significantly. Second, because the ED-PVR curve is relatively flat, that increase in stroke volume occurred with only a modest increase in left ventricular end diastolic pressure, that is, the pressure at point 1. And third, while the systolic and diastolic blood pressures both increase, the systolic increases more, resulting in an increase in the pulse pressure, which is the difference between the systolic and diastolic pressures, and which is the primary determinant in how strong a person's pulse feels. When preload is decreased, for example by giving a diuretic medication to increase the production of urine, we essentially see the opposite. Point 1 moves down and to the left on the ED-PVR curve, and the peak of the systolic ejection curve is lower. This leads to a decrease in stroke volume and a decrease in the blood pressure. Now, what about changes in afterload? If afterload is increased, for example by administering a vasoconstricting medication like phenylephrine, or an illicit substance like amphetamines or cocaine, the systolic and diastolic blood pressures will be increased, which raises the locations of point 2 and 3, the latter of which still needs to stay on the ES-PVR line. This results in a decreased stroke volume. Exceptions to this diagram include situations when afterload is increased due to pathologic narrowing of the aortic valve, called aortic stenosis, or pathologic narrowing of the left ventricular outflow tract, as might be seen in a condition called hypertrophic obstructive cardiomyopathy. In both of those cases, the peak of the PV loop itself will still look like this, but it will not represent the systolic blood pressure, as there will be a gradient between the LV and the aortic pressure that persists throughout systole. When afterload is decreased, for example due to the administration of vasodilating medications, the systolic and diastolic pressures will be lowered, which lowers points 2 and 3, resulting in a lower LV pressure at end systole and an increased stroke volume. Now, contractility. Remember that contractility is the intrinsic strength of myocardial contraction that is independent of preload and afterload, and which determines the slope of the ES-PVR line. If contractility is increased, the line is steeper, so point 3 gets shifted up and to the left. This results in a higher blood pressure, particularly systolic blood pressure, and a higher stroke volume. Decreased contractility, as may be seen in heart failure, has the opposite effect with a less steep ESPVR line, a significantly lower systolic pressure, and a lower stroke volume. And for the last of the 7 examples, what happens with decreased compliance? Decreased compliance increases the slope of the ED PVR curve. The pressure when the mitral valve closes is reached at a lower left ventricular volume than normal. The most notable consequence to the PV loop is lower stroke volume, but blood pressure is also decreased. Now, there's one huge caveat to this entire PV loop discussion. While this discussion so far may have implied that each parameter can be changed independently while the others remain constant, in a real person this is not true. Any process which alters one parameter will necessarily alter at least one, if not more than one of the others. So while these examples all have common clinical relevance, they also are simplified, idealized descriptions of real-world physiology. The last section of this video will cover the closely related topics of myocardial work and myocardial oxygen consumption. O2 consumption, abbreviated in physiology as V.O2, is affected by the heart rate and the work performed by the heart per cardiac cycle. The total cardiac work is comprised of 2 things, neither of which is easy to directly measure. The external work, which can be thought of as the work of ejecting blood from the heart. This is the sum of the integral of PdV and the term for the kinetic energy imparted on the ejected blood. The first term is equal to the area bounded by the PV loop, which is sometimes called the stroke work, and the second term for kinetic energy for a heart at rest that is not exercising is usually small enough to ignore. In addition to the external work, there is also predictably internal work, which nebulously includes everything else, such as the work of maintaining wall tension at times other than during systolic ejection. This is sometimes represented as this part of the graph and labeled mechanical potential energy, or PE. Despite my best efforts, I have not located a derivation showing this triangular-shaped area to be a mathematically precise representation of the internal work of the heart. Regardless, it can be used to demonstrate how hemodynamic changes that affect the PV loop can change the fraction that the external work makes up of the total work. In other words, by increasing the amount of external work relative to internal work, it increases the percentage of work and thus oxygen consumption that is used in generating cardiac output, which can be thought of as cardiac efficiency. While this framework for cardiac work and V.O2 is common in textbooks, I find it to be confusing. Luckily, for the purposes of clinical medicine, it's not critical to understand its nuances. What is important instead is this list of the overall determinants of myocardial O2 consumption. The most important is the heart rate. Preload, afterload, and contractility all also contribute, though preload is a relatively minor contributor. Sometimes this phenomenon is described as pressure work requiring more oxygen than volume work. For example, patients with severe aortic stenosis who have high afterload commonly develop angina, that is, chest pain caused by insufficient delivery of oxygen to the myocardium. However, patients with heart failure who have high preload very rarely develop angina as a direct consequence of that hemodynamic change. The last major determinant is the heart's basometabolic rate, which is relatively constant outside of extreme metabolic derangements. Because cardiac work and myocardial oxygen consumption are essentially impossible to measure at the bedside, some surrogates have been adopted. Stroke work is sometimes estimated as the stroke volume times the mean arterial pressure, and the rate pressure product, which is equal to the heart rate times the systolic blood pressure, can be used as a surrogate for V.O2. Here is one last way to discuss how the heart uses oxygen. As you might guess, the majority share is for contraction. However, as discussed in the lesson on excitation-contraction coupling, myocardial relaxation is also an ATP-dependent process. Some oxygen is used for basal metabolism, and the smallest share is for electrical activation, including all the ATP-dependent ion channels that allow the creation and propagation of action potentials. In summary, the cardiac cycle includes isovolumetric contraction in early systole and isovolumetric relaxation in early diastole. The dicrotic notch is present in the aortic pressure tracing at the transition from systole to diastole, and notable central venous waveforms include the A wave for atrial contraction, the X descent, the V wave, and the Y descent. The PV loop is a time-independent diagram of a single cardiac cycle. It illustrates stroke volume and both the systolic and diastolic blood pressure. The end-diastolic pressure-volume relationship is curvilinear, and its slope is determined by LV compliance. The end-systolic pressure-volume relationship is linear, and its slope is determined by contractility. Alterations in preload, contractility, afterload, and ventricular compliance all lead to predictable changes in the PV loop. Cardiac work is the sum of the external work, which is roughly equal to the area within the PV loop, and the internal work. Myocardial oxygen consumption is related to heart rate and the cardiac work performed per cardiac cycle. Heart rate is the most important determinant of myocardial V.O2. And last, contraction, relaxation, basal metabolism, and electrical conduction all require oxygen. That concludes this video on the cardiac cycle and PV loops. If you found it interesting and helpful, please remember to like and share it, and consider subscribing to Strong Medicine for the rest of this ongoing series on cardiovascular physiology, as well as a diverse collection of other medical topics.